Hi everybody, my name is Rhys Barber. I'm one of the audiologists here at Audiology Associates.
Hello everyone, I'm Katie Watkins and I'm one of the trainees here at Audiology Associates.
So this is actually a pediatric patient, which is always a more challenging wax removal to do, but what makes this doubly challenging is that this young man has actually been using cotton buds and impacted all of this wax against his eardrum. And when I mean against his eardrum, I mean literally on his eardrum. So he's having lots and lots of difficulty with his hearing. And when I first started moving this wax, your heart kind of sinks a little bit when you see this, because it's just so squished together and so rock solid in here. And these are always more difficult to do, even with an adult size ear canal, but with a pediatric ear canal, it's much tougher to do.
Even watching it, I thought there's no way.
Do you know, I had my doubts, I gotta be honest. On this one, I thought, I'm not sure where this is going to go. I don't come across many where I think, oh, do you know what, I don't fancy my chances of getting this out today safely. This was up there. This was a tough old one to do. The reason being is the wax is actually physically stuck to the drum, and also to the canal wall surrounding the drum as well. This is actually a right ear, so we've got a lot down in the anterior recess, which if you're new to the channel is the little sort of valley that's just run in towards the front of your head. So on the right side, it'll be kind of this side of the canal. And there was a lot wedged in there, and it had dried out and gone super tough, hadn't it?
Been a very, very long cotton bud user.
Yeah, I would have said so. Look at this. I mean, my advice to this patient when they left was just go home and just throw every single cotton bud you own in the bin, because it was an absolute beast to get out.
He didn't seem too impressed with that.
No, he didn't. No, he didn't. In fairness, no, he didn't. But it's it's just so difficult. Wax removals can sometimes be quite taxing to do, and you have to. We look at the skill level that you need, and that's not blowing my own trumpet. Any wax removal professional, it's hard, to get that wax out. You've got to be so mindful of discomfort for the patient, not causing any damage, not touching any structures you shouldn't do. If you guys use cotton buds and things like that, it just makes our job so much harder. And yeah, it was a tough old one to do. I think the patient had tried to use some oil, but what you'll notice is they've got very dense hairs on the outer portion of the ear canal. And I think that had blocked a lot of the oil from getting to where it needed to go, unfortunately. And it also impedes our view, because I've just had to put a little bit extra in there now. Yeah,
because even when you put the oil in, you could see that it was the deeper down we was getting into the canal. We were struggling to get into the canal there.
Could not get it down there. And as much as I think I introduced oil, we use a spray olive oil. So if you're interested in the olive oil that we use, if you check out the link tree in the description, you can actually get it. It's an Amazon affiliate link, so we do earn a couple of pennies from Amazon as well when you buy it from them. But that olive oil, we were putting a few sprays in there, and I think I did that. I want to say three or four times.
I think, yeah.
Just because as we were taking the surface away, we talked about this in the last video, how oil works. The wax is bound by lipids and fats, and basically the oil obviously is another fat, so another lipid. So when it goes in, it helps to kind of loosen and dissolve that surface layer. And we were having to do that repeatedly, because every layer we took away, there was another hard layer behind it.
I think at the end we said to him, just tilt your head down there and get it in yourself.
You still got to spray as much. We just said, please lean across, just so gravity did some of the work for us to get it down there, because it was really, really stuck in. And it always caused problems, because with pediatric, you've been looking at pediatric canals today, there is an obvious size difference. Do you know what the sizes are?
I don't know the actual size of a pediatrics, but I know an adult's canal is about an inch long.
Yeah, so about 2.5 centimetres, about 2.7, I think it said. For children, that can be a lot shorter, all right? So what you're looking at is a much shorter canal, much narrower canal, because obviously the structures are just the size of the head, basically, is a lot smaller, so the canal's a lot smaller. But the other thing you've got is with pediatrics, you've also got the cartilage is a lot softer. It's not quite as sort of fully formed.
Okay.
So you get a lot more bend to that outer third of the ear canal. Right. So you've got to be a lot more cautious when you work in that outer section, because it's much easier to kind of, because normally with adult ear canals, there's a little bit of rigidity to it.
Yeah.
But with peds, you're going to be pressing against that canal, because it's got a bit more give. You've got that propensity to just
you haven't got the well, like a wall then to push against.
You got it. That's right. Yeah. So you can end up, causing a few issues in there as well. But now we're just starting to uncover the eardrum. We can see that how hard this is, and this is. I thought, perhaps we might be lucky and it's sitting just off the drum, but no, it was literally on the drum all the way through. So you might see a lot of blurring on the camera. I can't really help that, unfortunately. It's where we've put the oil in, and those tiny little hairs are sort of just clinging to those tiny little hairs. Lots of people ask, do we trim the hairs? We don't trim the hairs. And they ask, okay, well, if you don't trim it, why don't you trim it?
Okay.
The hairs really have a quite an important job.
They need to be there, hence the reason why they're there.
Yeah, so those little hairs you can see there, their job is to stop any bigger bits of dirt, debris, dust, that kind of thing, blowing into the canal, because the last thing we want is dust and debris getting in there, because that could potentially be carrying bacteria into the canal, and then you leave yourself at risk of things like infections. So they do help with protecting the canal. So if we can get away without trimming those away, I've got to be honest, I can't think of anybody I've ever had to trim the hairs. I may have somebody who's got really dense, thick hair. I might, if we've struggled, I might say, look, do me a favor, just trim it. Because they can trim it themselves. They don't need me to trim their hair. But they can trim those hairs. Barber by name, but not Barber by nature, unfortunately. So they can do it. They can do it themselves and get that out on their own, and then we'll get them back for a follow up then. But
going back the differences in the ear canals between adults and pediatrics. Is that why children are a lot more prone to infections? Because they got a lot more factors that could cause them, like the shape of it can slowing down the drainage of the fluid. And
you've got tiny, because if we talk about the ear canal part, with the canal being a lot smaller, they find it a little bit more difficult sometimes to expel things like wax and stuff as it builds up in there. So they are a little bit more prone to infections. And younger children, you do tend to find that kind of age 2 to 3, you will find they are a little bit more prone to infections just because of the size of the canal. But also, what you're talking about as well, with pediatrics as well, you don't tend to find that there's not quite as much of a bend into the canal, but also there are things like the eustachian tube, which is the tube we use to equalize or pop our ears. In adults, those stand sort of quite straight up, so it's very easy to drain any excess fluid from behind the eardrum and get air in. In children, look at that, look at that eardrum flexing there as we tried to pull. So you can see just how welded on this poor young one's young one. That's very odd. This poor kid's eardrum, but with eustachian tubes, because they're not stood as straight as they do as you're in an adult, you are more likely to get things like middle ear infections and glue ear as well. So those are more common. So there are some hearing issues which are far more common in kids than they are in adults. So you can see I'm struggling, I'm pulling on that one section, and I could actually see the eardrum starting to flex a little bit. Now, if we remember our eardrum anatomy, you kind of bottom 2/3 of the eardrum, if you like, that's the kind of stiffer, the pars tense, or don't stiff part of the eardrum, and then the top portion of the eardrum is called your pars flaccida, so flaccid, flexible, floppy. So imagine that, and so what we've got there is this bit is actually in the pars flaccida, or attached to the pars flaccida. So there's a little bit more give. There's not any of those circumferential and radial fibers in that kind of top area. So it just means there's a little bit more give to the eardrum.
Yeah, because it looks really thin as well. The actual eardrum itself, it's not very thick, is it?
No, you took it three layers thick. So you've got your surface layer, which you can see here, which is the outer skin layer, what we call the epithelial layer. And then in the middle, then you've got these fibers that imagine like those like an ordnance survey map. You've got the topographical maps, I think they call them. So when you look at something that's higher, you get these rings that go around, they get closer together. Do you know what I mean? Yeah. So imagine the eardrum looking a bit like that. So you've got all these rings that run around the eardrum, and you've got these kind of fibers that come outwards as well. So what you end up with then is that gives the eardrum its structure, and then the back end, which is the lining of the middle ear space, is mucus producing cells.
Oh, okay.
So you've got mucus at the back, then you've got the fibers giving it its structure in the middle, and then you've got the surface section, which you can see, and that's the skin cells then on the front, which then form the ear canal wall skin.
So because the wax was so literally touching the eardrum, because he obviously kept using cotton buds. Would that eventually, potentially pierce that eardrum? Yeah,
the depth that we were going here, if we were talking this wax, I think is probably, if you said it was about 2 mil thick, maybe 3 mil at its thickest point, So if that patient had just gone that much further, they would have been hitting their eardrum. And you can perforate your eardrum with cotton buds. When you have a perforation like that, it's usually known as barotrauma. It's when you push something in, you cause physical damage. So yeah, it does happen. And I remember vividly one case we had when I worked in the NHS, and that was somebody who was cleaning their ears and they were stood behind the bathroom door, and somebody had come through and flung the door, hit their elbow, and woof, that went straight through their eardrum. So yeah, it does happen, and you know, this is why we say to people, try not to use them. I know you get a lovely sensation when you do it in the ear, but honestly, just use a bit of olive oil, and that's all, you know, medical grade olive oil, don't forget.
Or don't use them behind doors.
Yeah. Wide open spaces, nobody else around, no wind. Yeah, so that's your option. You either do it in the middle of a field with nobody around, or don't. Yeah, or just don't do it at all. It's probably easier. So I've just got these last couple of pieces. So this is just after we told the patient, you know, we put the oil in, we got them to tilt over, and you can see even just taking these little bits off, you just see that little bit of a flex. So you've always got to be that little bit more cautious with these types of removals. You know, I wouldn't expect. You know, somebody brand new to doing this. There is no way on this earth would I expect somebody to do this, and you really have to know your structures of the ear canal. You really have to have a lot of experience of wax removal. First of all, you should be having that anyway if you're dealing with pediatrics. It's a very, very different ball game with a pediatric patient than it is with an adult. But also when you're doing deep removals like this, you've got to have your wits about you when you're doing this kind of stuff.
And you've got to have the bang on technique as well. I mean,
you've got to have, like me, you've got to have really steady hands if you're doing this. You've really got to be. You're talking. I do this analogy a lot, and I guarantee you guys are all going to do the same thing now. But if you look at the tip of your little finger, that is as big as your eardrum is. So the surface of the tip of your little finger, that's roughly the size of the eardrum. So you can see how small an area we're working in. Now you're looking, if you're an adult, you're looking at this as an adult pinky. You imagine that as a child's eardrum, you know, at the tip of a child's finger, and that is the size we're looking at on here.
That's crazy.
It's mad, isn't it?
I'm really shocked that this patient didn't have much pain or discomfort though.
I really thought they would have done. Yeah.
Didn't complain about anything like that. Just that his hearing he lost a bit of his hearing.
Yeah, and you know, looking at this hasn't been like this for days.
No.
This is months looking at this, you know, and the gent was actually, he was due to go on holiday, which is why sometimes with this I would have said, look, just oil it, come back in a week. Yeah. But the gent was due to go away on, and it's kind of like it was a really big holiday for him. And he was off abroad for a good period of time, I think. So basically, I didn't want to leave it because ideally I would have got him back in a week's time, but he was due to fly on the weekend. So I thought if I can try my best to get this out, and you know, you are checking with the patient, are you okay? Yeah. Are you all right for me to continue, especially pediatric patients as well? Yeah,
you didn't even want like a little break in between or nothing, did
no,
he? Just sat there.
He just did the whole thing. Fair play.
Nothing.
Yeah, absolute trooper. He was so good. And there you go. We're really starting to loosen this last bit. I think I did get about halfway through and say to his relatives who were sitting in the room with us, like, I don't know if I'm going to be able to get this out today. No. And they were like, oh, they were so disappointed. I was like, oh, okay, I'm going to really try. And luckily, we did get it out.
A bit of patience is all it took.
It is, and that's the key to these. You know, with any kind of wax removal, don't rush it. If you're somebody, I mean, I don't know whether people who do wax removals watch these videos as well, but if you're new to wax removals, if you're watching this, I know some people use our videos for training videos and stuff. You know, if you're new to doing this, just take your time. There is no rush, you know, and if you feel that you can't get it all out in one visit, there is nothing wrong with getting that patient back for a second visit. You know, you see us do this, and we do in this first visit all the, you know, not all the time, but a lot of the time they come away in one visit. Don't forget, I've done thousands and thousands and thousands of ears. When you're first starting out, it's not unusual to be getting patients back a lot. No. Do you know what I mean? For follow-ups, because you've got to work within your confidence level and your ability level, and you mustn't let your confidence outweigh your ability. Yeah. You know, that's when mistakes happen. You've always got to have your ability level in the back of your mind, and if you think this will be much easier if I can get this patient back if they've softened it a little bit more, send them away to soften it a little bit more and get them back in. Don't try and struggle to do it first time.
I suppose doing that as well, you're ensuring the patient's safety as well, aren't you?
Massive. It's always
if you keep poking and poking and poking, it's just not going to be comfortable for that patient.
Well, I know I wouldn't want it done to me.
No, exactly.
And this is what you've got as a professional. This is what you've always got to do, is you've got to put yourself in the position of that patient.
Yeah.
So when you're treating that patient, you know, if you think I wouldn't want to have this done to me, then it's not the right thing to do with that patient either.
No, absolutely.
I mean, it's always got to be in the back of your mind. But looking a heck of a lot better, and the patient could hear so much better.
A lot, instantly, wouldn't it?
It looks super pathetic on there, but it was a lot of work. So we are 7/8 of an inch.
2 centimetres. Thanks, Rhys.
That's all right. So yeah, thanks guys for watching our video again today. If you do enjoy the videos, don't forget you can always like, heart, share, follow and subscribe for me. If you thoroughly enjoy the videos, you can also consider becoming members of the channel. That way then you get to see even more videos every single week. But as always guys, in the meantime, take care of yourselves.
Take care of your ears.
And take care of one another. And myself and Katie will be back for Monday's video. Don't miss Monday's video, guys. It is brilliant. We've got a lovely foreign body, which I've never taken out before. Even Katie was shocked. So we'll see you for that one on Monday. Bye, everybody.
Bye, guys.